Thank you everybody for joining today's webinar, The Use and Misuse of Antenatal Corticosteroids, New Guidance and Simple Solutions. This webinar is hosted by Hologic, and I am pleased to be joined by Professor Andrew Shennan, Professor of Obstetrics at King's College London. My name is Susan Hepworth, and I will be moderating today's webinar. The brief agenda is as follows. After my brief introductory remarks, I'll turn it over to Professor Shennan for his presentation today. He'll speak for about 45 minutes, and following his presentation, we will have time for question and answer from today's webinar attendees. After about 15 to 20 minutes of question and answer, that will conclude today's webinar.
Just to say thank you so much for the invite to come and talk on this topic. It's a topic that I feel strongly about. I think it's one of those areas where we definitely can do better. And it's great to have the opportunity to share with you my thoughts and some of the literature around how I think we can achieve that. And I'm really open to hearing people's views because it's one of those evolving areas that I think needs debate and discussion. So the title is deliberately a little bit controversial, The Use and Misuse of Antenatal Steroids. To start with, I'm just going to make sure I can advance this quickly, just talk about my declarations. As a clinical academic, I obviously have funding from a number of research sources in clinical trials. I've invented a few devices, some related to preterm birth. I have a small interaction with commercial companies. However, none of these are related to a direct personal sort of financial interest. I just really wanted to start with a picture of what I think we care about, which is the women we look after and our babies. And actually this picture on the right of Noah was taken last week. And I think we struggle to prevent preterm birth. We do manage it though, and one of the interventions, of course, is to improve outcomes, is giving antenatal corticosteroids. And Noah was born at 25 weeks in 2010 after a rescue stitch. And she got a course of antenatal steroids, which we were able to time within a day or two of her delivery. And here she is literally last week doing extremely well at school, and essentially the sort of has had, from a health perspective, is in perfect health. So a great story that we are all striving for. I also just shoved in this picture literally in the last 10 minutes. This picture was taken 30 minutes ago from my clinic, which I've just left. And this is Katie with her two gorgeous boys. Max on my right. Katie lost two babies mid-trimester and came to us. And we managed her with stitches that didn't do that well, and she was admitted to hospital with a very short cervix, and we thought Max here was going to deliver at sort of 22, 23 weeks, and actually he went on and delivered, Katie reminded me just now, at 39 weeks. And even in those people who we are extremely worried about, who have every risk factor in the book, have every clinical sign that they're going to deliver, will frequently not deliver. And we will often give treatments that are, in retrospect, unnecessary. And I think this is a really important part of our management. Fortunately, even high-risk women do well a lot of the time. And the onus on us is to direct management appropriately. And I want to just spend today to talk a little bit about the benefits and risks of steroids and how we might improve our practice. And it goes back to the story that I'm sure we all know and are familiar with, but just to remind you, I quickly looked it up again because it's interesting. So Liggins, back in 1969, working in Auckland, had an academic research interest in preterm birth. He had noted that sheep, when they had abnormal fetuses with anencephaly and other brain abnormalities and pituitary issues, would often have very extended gestations, and came up with a very interesting theory about fetal contribution to the initiation of labor was highly related to the fetal brain. And the way he set about to kind of look at this was he went to a farm 80 miles south of Auckland and gave sheep some steroid injections as a way of investigating initiation of labor. During these experiments, some of the babies were born early, and one particular one was born extremely early and normally wouldn't survive because it was so tiny. But it did survive, and it had breathing difficulties, but lived for a few days and then died. And he did an autopsy on that baby and showed that its lungs were incredibly well aerated, and really was the first observation that these antenatal steroids given to the mothers could potentially improve the outcome. And he went on and did a clinical trial of, I think, 287 women randomized who'd been given antenatal steroids, very much in the same regime and dosage as we know and love today, betamethasone. And in fact, the evidence base is based on those doses and regimes, and the science behind why those doses and regimes is far from sophisticated. It's simply based on what seemed to be a plausible good thing to do at the time, and it hasn't changed. And although there's lots of ongoing research, it's worth just noting that we don't really know whether lower doses or different dosing regimes are better or worse, because we simply have gone with the evidence base. And as many of you know, the Cochrane Collaboration is a UK-based organization which tries to collate evidence to present to us clinicians around the world, to give us slightly more substantive evidence on a meta-analysis basis on interventions from randomized controlled trials principally. And you may not know, but this particular logo that they use is the logo of the initial 7-trial meta-analysis of antenatal steroids for the prevention of respiratory distress. And it became a hallmark of evidence-based medicine, not just in our specialty, but throughout the world, in all specialties, and hence the logo for Cochrane. So it's a really established and important success story of evidence-based medicine and how it improves outcomes. And we in our profession can be proud of our contribution to this. And I'm just going to select one of many analyses that have been performed over the years to demonstrate the benefit, which is definitely established now in dozens of clinical trials, good, well-controlled prospective randomized controlled trials. And this just graphically illustrates the benefit of, on different endpoints. I actually selected one that the WHO put out more than 10 years ago now, but it's pretty much what is our evidence is based on. And Justin Hofmeyer, who I know very well from South Africa, did this one. I like him. He's a very sort of evidence-based guy, so I thought I would show off his efforts. And so we see this quite important, both clinically and significantly, reductions in baby death, in RDS, brain hemorrhage, issues with the gut, infections, so all very useful. In these meta-analyses, we often see this as well, that there is benefit related to lung disease and baby mortality with repeated doses, but this effect of perhaps an increase in growth issues in those babies that keep getting steroids. And I think this is nothing new to the audience, I'm sure, an established intervention. And because of this, it's been promoted quite rightly strongly around the world. And I'm just going to select one particular guideline I happen to be involved with, which is the FIGO guideline. I currently chair the Preterm Birth Committee for FIGO, and Jane Norman and her group in Edinburgh have a big expertise in this area. Sarah Stock is now very interested in doing research here, and we came up with this guideline, and using betamethasone or dexamethasone, and basically pretty much like you're all used to for women with singleton or multiple pregnancies who anticipated to deliver between 24 and 34 weeks, course of prenatal corticosteroids should be offered. And we're now honing in now on the time frame that is more optimal, and the evidence now is pointing to 18 to 72 hours, so slightly more specificity there to improve the outcome. But if you are going to deliver in less than 18 hours, you're not wasting your time, and we still advocate that you should get antenatal steroids. And you can go around the world in any number of guidelines, and there are variations of this which are fairly similar. The problem clinically is, of course, any of you who work in preterm birth will know that many women come through the door in threatened preterm labor, and huge numbers will not deliver in the next week, even though you're worried they have labor or uterine activity that warrants action. And Liggins actually, in his original studies on sheep, on the first clinical trial he did on women following his sheep evidence, he advocated giving tocolysis, and that time it was salbutamol or ethanol, as was popular at the time, to stop labor in an effort for the steroids to work. So all those initial ideas about how to give the drugs were really just established off the cuff as a good idea, and really became established in practice. And because it was successful, the evidence around those interventions and the details around how to give and what to give have really been promoted time and time again. And I think we've learned in time that not all the things we suggested may necessarily be good. So the bottom line is, because threatened preterm labor is so common, we end up giving huge numbers of antenatal steroids to women who don't deliver, particularly in the next 7 days. And these two trials from Peaceman and Wing happen to be preterm birth prediction studies, and you can see that tiny numbers end up delivering in the next 7 days in these trials. And even in more kind of robust trials where people are a little bit more judicious in working out if they're in actual labor, that figure rarely goes above 10%. The Netherlands are particularly good at diagnosing preterm labor clinically, but you will still get 90% of people going more than 7 days. And of course, most of those women end up getting antenatal steroids. This data actually comes from my group. We do many trials in preeclampsia, and Alice Hurrell very nicely put this together for me. This is women who get indicated preterm birth related to early onset preeclampsia. And this to me was quite a shocker. We have 250 women who've come into clinical trials in UK hospitals, and you can see that most of them get antenatal steroids, which I guess is a good thing. These are babies being born before 35 weeks, so 80% or 60%, but only a minority get steroids within 7 days. Now, when you're going to deliver somebody for preeclampsia, you know when they're being induced, you know a likely timeline to delivery, or they may even be having a cesarean, and it's sort of unforgivable not to get it right. So the fact that people don't get it right, give the steroids too early, I think in itself is, a clinical problem, which is so easily rectified. We're just seeking to get this published at the moment. And I just want to take you back for a minute to the studies done on neonates a while ago, and just to point out that our neonatal colleagues worked out very quickly that steroids given to the babies directly, the neonate is, after all, the fetus that is ex utero, same physiology, same potential benefits and harms. And it became very clear from giving early treatment of neonatal steroids that this was a bad thing. So although there was benefit, as we see in antenatal steroids, on chronic lung disease and some other things, there were a whole bunch of bad things like GI bleeding, perforation. And what is also shocking, if you look at the numbers needed to treat or harm there, the numbers needed to harm are relatively modest, so often single figures for quite important endpoints like cardiomyopathy and hyperglycemia and growth failure. And you only need to treat 2 or 3 babies to cause this problem. And it's no surprise that our neonatal colleagues do not rely on steroids as a way of reducing respiratory problems and improving outcomes. I also want to show you some data from Jerry Visser, who's a very respected colleague in the Netherlands. And he describes steroids, which I quite like, as potent drugs with some beneficial side effects. This very small but important study was 22 infants that were born but died within 4 days, who had half had received steroids and half who hadn't. And the pathologists looked at the density of neurons in the human hippocampus, and you can see that in those fetuses who did not get steroids, there is a much higher density of neurons compared to those that did get antenatal steroids, where there's a much lower density of neurons. And this is just simple barn door physical insult that affects neuronal growth. And I think this, although this is a tiny study, it's a really important one, illustrating just the impact of steroids on neurons. Does this matter? Well, there is evidence, and I think it's quite good evidence from studies. And this one, the term steroid trial of cesarean sections, that in the randomized design, they looked at the educational and behavioral outcomes of these children, and they were significantly worse, in terms of teacher assessment of their abilities at school. And this is sort of criticized, that teacher assessment is somehow poor, but in a randomized design, I think teacher assessment of your intellectual capacity is perfectly legitimate, especially if you're comparing two groups and you're blinded to the allocation. And I think this is a really important thing that we need to share with women when we are counseling them as to the risks and benefits, that there is the possibility of issues that result in your child not doing so well at school level if they've received steroids. And of course, there's often a price to pay, and we have to be upfront and honest about it. Interestingly, in these trials, there is no real difference in admissions to hospital and asthma, and I think this may reflect the fact that the steroids are given at term when they might not make so much difference, but this low academic achievement is definitely significantly worse. And other big studies in Finland, where they're quite interested in this area, they've gone on and looked at steroid-exposed infants who end up actually getting more medical care compared to their non-exposed matched controls. And the babies that go on and deliver at term, who got steroids earlier on from their mother, were significantly smaller. So it's not just the babies that deliver preterm that are smaller. And this more recent study from 2020 from JAMA, large numbers again from Finland, has shown that corticosteroid treatment is associated with mental and behavioral disorders in children. So they're all pointing to an insult on neurological issues in the babies. And I don't think anyone would deny that we need to keep an eye on this and always look at the risk-benefit in our decision-making. So we know that steroids are excellent at improving outcomes. We know they potentially have an insult which we have to be careful of. I think the other thing we need to look at is who are we treating and why are we treating them? We're worried about RDS and we're worried about serious outcomes, which are pretty much clustered in that early period, sort of 22 to 26, 27 weeks. And you can see from this graph very nicely how there's a rapid improvement in baby survival and in reduction in morbidity over a very tight window. And once you hit 32 weeks, there's very little improvement in those serious endpoints. Now, RDS in more recent studies, in this case, in the Sinclair one here, you can see becomes vanishingly rare, very small percentages, certainly beyond 35, 36 weeks. And I think in contrast to that, if you look at neurodevelopmental outcomes in late preterm, there's a definite worsening, in this case, special educational needs in that 36 to 39 window, babies born early compared to term. And so it does seem to me that we are treating the worry about respiratory problems with a drug that is known to make neurodevelopmental problems worse in the late preterm period. And again, we have to kind of keep a close eye on the risk benefit of treating late preterm. And this is a very controversial and highly debatable area. We have to just think about what we're doing and what the evidence is around doing it. And I worry about the neurodevelopmental outcomes in late preterm more so than the respiratory distress ones, which arguably are more short-lived and more likely to get better. Now, our colleagues in North America have been very keen on giving late preterm steroids 34 to 37 weeks. So it gives us an opportunity to look at that evidence. And it's been backed up by clinical trials that have shown a certain improvement in that group. It has been criticized. This is Jerry Visser's comment, which I copied. It will result in more than doubling of steroid use. So there's this rather strange paradox, as I've mentioned, that the less you need it, the more you get it, which may be justified, given there's a lot of babies born in the late preterm period. But what it means is there's a large numbers needed to treat, and I want to talk a little bit about that. And of course, although follow-up data is appearing in some countries, it's still not very prevalent in those parts of the world which use it a lot. So what about this unnecessary treatment? And I have, for the purposes of this talk, just modeled it a little bit. If you give antenatal steroids, it's not just a matter of numbers needed to treat to prevent a case of, say, RDS, but it's also the numbers you screen who don't deliver that end up getting the treatment. So unnecessary treatments is basically multiplying the numbers screened by the numbers needed to treat. Now, in most studies, the numbers needed to treat to prevent one case of RDS in babies that are actually born early is about 20. You then have to multiply that by the numbers who are screened who don't deliver. So 10 times, at least 10 times as many babies get steroids who don't deliver in threatened preterm labor. And so at 24 weeks, you have to treat about 200 babies to prevent one case of RDS, which you know, RDS can be serious, and we all agree it's potentially justifiable, and it also can reduce mortality and other important endpoints. But at 37 weeks, where numbers needed to treat to prevent a case of RDS is at least tenfold, so these are all very conservative modeling, you may have to treat 2,000 women to prevent one case of RDS. And I think what it's sort of suggesting is that you need to be happy that the harmful side in these 2,000 babies justifies the benefit in the one baby. So the risk-benefit ratio has to be quite substantial to justify giving a lot of steroids. And I think we have to think this rather than just saying, oh, steroids are good, let's just give it to everybody, because even a very small harm is multiplied up significantly given the clinical scenario of how these women present. And I'm part of the European Association of Perinatal Medicine guideline group. We're hotly debating this issue. The wording suggested for antenatal steroids between 34 and 37 weeks is it should be restricted to prospective randomized trials. These are currently being debated, but you can see how strongly people feel about that practice around the world. Now, my interest in this area really came about when I was lucky enough to attend the guideline development group for the WHO in 2015, where one of my fellows was involved in the methodology. And here was the evidence that was presented to us by large groups of people, and we discussed it for 3 days. And this is really where I got my interest in this area. I'm just going to remove all the significant, non-significant findings. And you can see what we're left with here is that if you give antenatal steroids in less than 24 hours, you will significantly reduce death. If you give it in less than 48 hours, you will significantly reduce death, same degree, and RDS and cerebral hemorrhage. So it's looking like the serious endpoints like death and hemorrhage are only reduced if you give the steroids close to delivery and not reduced if you give them more than 48 hours. And RDS is reduced if you give it within 7 days, but not the other endpoints. And I think the old data, which didn't really have this evidence, has pushed us to give steroids early so we don't miss them. And we've caused a bit of a problem here. And as you can see from this meta-analysis, if you give them more than 7 days in advance, there is no benefit overall. And clinical trials have really backed this up very nicely. This data has demonstrated that if you've given steroids within that 48-hour period, 24 to 47 hours, you can see how neonatal survival is a whole lot better than if you give it more than 48 hours. And of course, once you get to 7 days, you know, it becomes worse, although in this study, that's even better than giving no steroids at all. And other studies here have demonstrated a very similar effect. The benefit is really in those steroids given within a day of delivery, and for serious mortality, or for mortality and serious neonatal morbidity, it's much better giving the steroids within a day, not within 4 days. So if you had a choice, you'd want to give it closer. Now, there's lots of important things with this, because in our enthusiasm to give antenatal steroids early, we end up pushing them later to the point of delivery and actually making their benefit worse. The other slight confounder here is most deliveries in the world happen not where I work and not where many of you work, but in Asia and sub-Saharan Africa. And when there have been clinical trials in antenatal steroids in this area where gestational age is not so certain and diagnostic criteria and ability is perhaps less opportunistic due to low resource, actually there was no benefit of neonatal steroids in this study. Mortality was actually increased and maternal infections were increased. So we can't just assume steroids are good everywhere, but it was a lesson that precision, giving it to people who are known to benefit from it, is a really important part of this. I think other studies now have demonstrated that steroids are good, but they have to be given in certain circumstances. Now, many guidelines around the world have looked at this evidence and quite rightly have started to change their tune a little bit about what we should be doing. So antenatal steroids, this is our preterm birth guidelines from the UK, which I was party to. And these are guidelines for commissioners and providers. We say give antenatal steroids from 24 to 33 plus 6, but optimally within 48 hours, which is similar to our FIGO guidelines. And then we stipulate a steroid to birth interval of greater than 7 days should be actually actively avoided. Obviously, that's a challenge, and I'll come on later on in the talk about how we might achieve that. And importantly, the NHS England has said, right, when we're going to collect this data and collect what is good about our behaviors, we don't just want to know how many steroids have been given to these little babies, but we also want to know were they given correctly. So the latest metric is percentage of singleton live births, less than 34 weeks, occurring more than 7 days after completion of their first course of antenatal steroids. So if you're given a second course, you failed. If you deliver more than 7 days, you failed. And actually, this percentage is a quite small minority in our current practice, as it is everywhere else in the world. And I think that's a really sobering thought, because we're not giving these antenatal steroids correctly. So actually, the corroboree of this is most babies who would benefit from antenatal steroids currently do not receive a therapeutic dose, and treatment only harms. And I think that is quite a sobering thought for most of us. And very recently, the SMFM have come up with a special statement saying something very similar. They're pointing out that the metrics currently do not take into account the timing of the steroids, i.e. giving them optimally within 7 days. And as I've already said to you, actually 48 hours or 72 hours is even better. And what they propose is a balancing metric that tracks how many people go on to term, because that actually is also bad practice given the potential harm of antenatal steroids as well. So I think that's all kind of slightly sobering, but given the value of antenatal steroids, I think it's really important we look at this carefully and be brave about withholding steroids. Don't worry about not giving them, because the women come back and they will receive steroids. And if they get them 6 hours before, that's not a failure. Actually, they will still benefit from those. And the price that comes with that is you've given a whole bunch of steroids correctly and improved outcomes. And overall, the total number of babies receiving beneficial therapeutic steroids has increased considerably. And just because you've got over this fear of not giving somebody steroids, because you think somebody's going to get upset with you, your neonatal colleagues are going to shout at you, why didn't you give the steroids? Because that's just a behavioral problem and a sort of medical legal issue that we need to educate our neonatal colleagues and our legal people about, saying it's not a good thing to give steroids and not deliver, because you are causing potential harm. So what is the solution here? Well, good clinical practice is the solution. Sensible decision-making, and like with the woman with preeclampsia, that should not be challenging. And I think women walk in the door with severe preeclampsia, if they're likely to go more than 7 days, do not give them steroids. Actually, you should be giving them steroids at the point you've made the decision to deliver, which gives you plenty of time to work in the sort of 24, 48-hour window if they're big induced. And even if it's a rush decision, if they happen to have an abruption, okay, you might miss 1 or 2, but you'll prevent this kind of majority who currently get steroids 7 days in advance, which is doing them no good. In fact, it's making a baby that's already got growth restricted problems even more growth restricted. So when we look at prediction, actually not just antenatal steroids, but most of the things we do in practice have a timing issue, and there is the need for good clinical acumen and potentially tests to improve it. Now, I do want to talk a little bit about antenatal tests and how they might help our practice. And there are 4 that I've been involved with that I'm familiar with that have been available in the UK. They are partiture, actin partus, fetal fibronectin biomarkers, and cervical length, which we all know and love. A simple kind of dictum, I think, which is important, is what do we want to know from a predictive test? Actually, sensitivity and rule out, I think, is far more important than specificity, because it is really bad not to treat somebody. I think if you overtreat, that is arguably more acceptable than missing treatments. And at a relatively modest risk, we as clinicians will tend to bring people in, give them their antenatal steroids, give them, make sure they're in a place that will be safe to deliver in. Whereas you want a very low risk before you send people home. And therefore, we generally want to weight sensitivity over specificity. And if you have a test that has a fixed endpoint, it's quite difficult to do that. There are 2 tests that are available that have been around for that requisite 17 years to get from invention to output: cervical length and fetal fibronectin. Certainly in my unit, many more people can take a fetal fibronectin than a cervical length, so that makes it a much easier thing to do. And I want to spend the first few minutes just sharing with you my experience of predictive tests and how we've got round the struggle of getting it right. And of course, because there's good evidence out there that these tests work and work in synergy, how do we get that into our head and know what the risk is? And rather than saying a test is normal or abnormal, which is a challenge, we actually can work out a risk. And so I'm going to tell you a little bit about the QUIPP app. I appreciate in some parts of the world, like in North America at the moment, the QUIPP app, although available from a software point of view, it relies on quantifiable fetal fibronectin, which I don't think is yet being marketed there. But before I say that, I just want to stress the fact that nothing beats good clinical acumen, and you shouldn't just do a test because it's there, because the woman walks in the door or because she's got pains. You need to ask yourself, do you need the test? Will the value change your practice? And is it going to help the situation? And I think if you do that and target these tests appropriately, 1, it's much more economic. 2, you actually end up making much better clinical decisions. So only use a test when it adds value. And that, I think, is a really, really important principle. My experience with fetal fibronectin started back a few years ago now. One of the first papers I published was 2005, where we used it in asymptomatic screening. And it is a remarkably good test to tell you who's going to go on and deliver in the next coming weeks or will stay pregnant. When we were doing these trials, we did some trials randomizing people to interventions in threatened with high risk on fibronectin. We kept the samples back, put them in the freezer, did ELISAs on them, and showed actually that the old positive negative test, which I think is currently used in the US, was we were throwing out information that could be used and useful. So in this study with Jim Kurtzman, who did the analysis with me, you can see that positive cases are in blue and green, that if you have low positive and high positive, you clearly get more value, and red and black are both negative cases, and if you have very low or moderately low, you get different outcome. And there's a very simple issue here, which is if you have a continuous variable instead of a fixed variable, you can change your need according to clinical risk. So if you have a fixed value of 50 nanograms, which is the current positive negative threshold for qualitative fibronectin, you have a certain sensitivity and specificity. But if you want high sensitivity, you just put in a much lower level. And that gives you much more reliable information that it's okay not to do anything to this woman because you know reliably she's not going to deliver. Conversely, if there are reasons you want to know she has a high chance, like you want to do an expensive therapy or move her with a helicopter or something, and you want more certainty that she's going to deliver, then you can take a higher cutoff. But you don't want to just take a cutoff and say the test is abnormal above that and normal below that. You want to actually use all the information. And we worked with Hologic to take the positive negative test, add in the concentration to allow clinicians to get that extra information so that it helps their clinical decision making. And the latest version of this, the Perilix, allows us to do that quite reliably. Our clinical trials, just to give you a flavor for that, you can see here that in symptomatic women, that if you had a low level of 10, your relative risk compared to a very low level was 5-fold. But if you went up to over 500, it was 50-fold. So there's a steadily increased relative risk of delivering before 34 weeks based on your quantifiable level. Even in asymptomatic patients, it was quite valuable. And you can see here that in 1,000 high-risk women who had a very low level, only 1 in 100 delivered before 30 weeks, and these were all high-risk women. And conversely, when the fibronectin escalated to over 200, the chances of delivering before 30 weeks became 1 in 5, or even nearly 50% before 37 weeks. And even in the short cervix, there was added value. So, for example, in this graph, you can see that in the 66 women with a very short cervix, if you had a normal fibronectin, you did a whole lot better than if you had a high fibronectin. And there are lots of studies we've done, I haven't really got time to go into, showing that fibronectin can be used in lots of different situations: low placentas, bulging membranes, after intercourse, after bleeding, from 18 weeks, Letz's, twins, congenital anomalies, and so on. And when it was first licensed, people often used these as exclusions because we just didn't know. But I think we've been very reassuring about the many clinical scenarios in which it can be used. Now, what really matters here in symptomatic women is what is the chance of delivering before 7 days? Now, you can see if you had a 50 cutoff, virtually nobody delivers in less than 7 days. But if you have a less than 10 cutoff, you can see that there's added value there. So the chance of delivering in less than 7 days is pretty low. And it's only when you get a level over 200 that the risk increases. So nobody delivered between 50 and 200 nanograms, which would have been a positive fibronectin on the qualitative test. But actually, if you're under 200, you have a fairly modest risk. Now, a couple of other groups have looked at fibronectin combined with cervical length, and I've plotted them here to show what is the risk of delivering in 7 days if you come in and threaten preterm labor. And you can see that if you have both a short cervix and a high fibronectin, nearly 100% of those women delivered in 7 days. Conversely, nobody delivered if both were normal. And if you look at this and compare them, you can see that fibronectin is actually better than cervical length. You can see that fibronectin is, when it's high and you have a long cervix, you still have quite a few people delivering early, but not the other way around. Obviously, the best thing is to combine them. And here's another study with another data set from Europe showing very similar data. So how do you remember the levels and the size and the continuous variable? You don't, of course. And so we decided to use a computer algorithm to tell us. And this is where we invented the QUIPP app. The QUIPP app is freely available online. And essentially, you can plug in the fibronectin level. The clinical scenario here: are they symptomatic? Are they asymptomatic? There were 3 or 4 clinical variables that added to the algorithm. We didn't throw out all the other important stuff. It just that this was over and above, and you didn't have to add in smoking and other risk factors because this was superseded by these tests which is the cervical length and the fetal fibronectin. And it gives you the risk of delivering before 30 weeks, before 34 weeks, and in the short term, before 1 week, before 2 weeks. And then you can decide what to do with that information. And we've got a nice little diagram there to show women who are worried about what you're telling them, and you can put it into context, whether this is high risk or low risk. And we have validated this and published. So those of you who understand ROC areas will know that a ROC area of 0.9 is pretty remarkable, and that's very good prediction. And even in validation sets, that means different sets of women who the algorithm wasn't made on has very reliable high prediction. Now, used in clinical practice, what does it do? Now, our nice guidance say bring in women and treat them regardless of their tests. If we actually modeled this on our actual patients coming into my hospital, and you can see here that the vast majority of people are brought in inappropriately because they do not deliver. A few are brought in appropriately, but very importantly, nobody was sent home inappropriately. And basically, if you picked a risk of 5%, for example, for your decision making, this is the benefit that you would instigate by using the app. We discovered on a Delphi consensus that people liked the 5% risk. Of course, you might want to change that according to your circumstances. But for the vast majority of women, they have an incredibly low risk, like less than 1 in 1,000. And that's very comforting that you're not going to deliver, that you can go home and not worry. And if you happen to have a risk of 3 or 4%, you don't say you're normal. You just say, well, that's less than the treatment threshold. Let's send you home. But you might want to get back here quickly if things don't go right. So it's not like an all or nothing, normal or abnormal. Now, we have done bigger clinical trials now. This was recently published in PLOS Medicine, where we've done this over 13 hospitals, nearly 3,000 women. We've used it in pragmatic clinical practice. And the first thing to say is it works brilliantly, even in clinical practice. So the prediction within normal clinical practice, with all the problems we have with multiple people using it and all the issues, still was a ROC area of 0.9. That means it's a very reliable test, and it relies on quantifiable fetal fibronectin. And there were 7 women who delivered in less than 7 days out of these 3,000 women who actually had a risk that was less than 5%. So you could argue that was a false negative. But you know what? All 7 of those women came back to the hospital, were all treated appropriately because they weren't told they were normal, but they were managed appropriately. So in the context of 13 hospitals used over years, this is a very safe tool, and we like it. And if you like predictive statistics, if you take the 5% threshold for your decision making, you get 1 in 4 women delivering in 7 days. You get over 99% not delivering in 7 days. And that's, those of you who like statistics, is a positive likelihood ratio of 13, which is really good. That's more than 10 is really good. There's the added value of a positive test and a reasonably good reduction of a negative likelihood ratio of 0.3. Not perfect, but with the right clinical counselling, it's perfectly reasonable not to treat those women. And it is recommended by NHS England. It's an online kit that our societies are saying, please use it. I now know that the app is used in 171 countries in the world. And with the COVID issues, it's been a great way to kind of keep people out of hospital and used safely. So it's a validated tool. It is being regulated and marketed as a medical device, and we have all the governance in place to make sure that it's safe. And, you know, whatever your belief in quantifiable fetal fibronectin, when you add it to the clinical algorithm, the clinical risk factors, and to cervical length, it becomes an incredibly useful tool that we've proven prospectively in clinical trials will accurately predict when you're going to deliver. And so, you know, there it is for you to use if you wish. We've also done that qualitative work around it, asking clinicians and women what they think. They loved it, basically, and it was hard to find people who criticized it. So going back to the steroid issue, I think the funny thing is that most people with a low level are low anyway, because they just got a low chance of delivering with or without a test. But when you do a test and you see it's normal, it gives you the confidence it's okay not to treat that woman. And withholding steroids suddenly becomes an acceptable thing to do. Oh, that woman's contracting, but I'm going to send her home and not give her steroids. And it feels really difficult when you first do it. But in 15, 20 years of practice now, I've never regretted not giving somebody steroids. And no one has ever come to me and said, why didn't you give me steroids? So it's just not a reality in clinical practice. Now, I'm going to finish off just last couple of really important slides, and that is just recognizing the impact it has on women themselves. This is one of my patients, Sue. Sue is actually a physiotherapist who came to me having lost a couple of babies mid-trimester. When we did the tests on her in her third pregnancy, she kind of couldn't believe it. She said, how can this test know I'm not going to lose my baby again? I just feel like I'm going to, because why would I be any different? And then the fourth time, there she is pregnant with her fourth, and she believed it, and she really could not sing its praises enough about how much it just made her feel better. That in itself may be a good intervention. But the best thing about the tests is showing them to women in my clinic. I saw we had 60 women today in my clinic, and to be able to have a tool that tells both us and them they're going to be okay, which is what is the reality for most women, even though they have these horrendous histories. It is just a great thing to be able to do. My very last slide is really what top tips. So I think the hard thing for us as clinicians is not to treat people. We're all terrified of getting it wrong. We're all terrified of being criticized. But that initiative has resulted in poor practice, and we're not doing the babies any favors. And we have to educate those people who criticize that, who worry about that, why this is a good thing to do. So my top tip is withhold steroids unless you're very likely to deliver soon. And you can always treat them when they come back. And paradoxically, you're probably going to treat them in a better therapeutic window closer to delivery, because it's very rare to deliver very suddenly. And most women will have at least 24 hours notice for you to give steroids. Far more babies will receive a therapeutic dose, and you will hugely limit the harmful effects of steroids, which, like it or not, are quite profound and increasing in evidence. Use your clinical acumen, and you can use these biomarkers to assess the risk assessment. It makes everyone comfortable. The test is telling you it's okay to do this, and that's one of its real benefits. Where possible, no more than 48 hours in advance. Of course, you can't get that right always. And obviously, if you don't get it right, it's okay to repeat them, but you shouldn't repeat them unless 7 days have gone by and you've still got a very high chance of delivery. So paradoxically, if you want to even higher chance of delivery to get it right, so you avoid these repeated steroids, which are known to stop the baby growing and have an insult. I really worry about this judicious use of steroids, or lack of judicious use of steroids above 35 weeks, because all the evidence is the numbers needed to treat is extraordinarily high, and we don't appreciate the benefits that we know about is being balanced by huge numbers getting the drugs, which have a downside. If you're reducing the IQ on 2,000 babies to prevent one case of RDS, I think if you said to a woman, look, you're very unlikely to deliver, we're giving you these just in case, but it might reduce the intelligence of your baby, I think far more women would choose not to have it and take the chance. And I think we have to get the counseling right. Just so you know, don't give it with sepsis. I think if you've got chorioamnionitis, you should not be giving steroids, or if you've got signs of septicemia. We don't know about dosing very well. It's based on old evidence. There's new work going on about this, but basically stick to local practice, and whether it's betamethasone, dexamethasone, dexamethasone's cheaper. If you look at the overall evidence, there's not strong indication to use one over the other. I have to thank my team who are still downstairs working hard in the clinic, so I can talk to you. But what an interesting area to work in. I think, any of you youngsters who are thinking about what to specialize in, this is a problem to stay. We have a lot to do both clinically and from a research perspective, and I would encourage you to maybe think of it as a specialist area.
Professor Shennan, thank you for joining us. We hope everybody has a great rest of their day and evening.
Great pleasure. Thank you.